Hello, class. Welcome to Chapter 13 Medical Conditions Involving Gastrointestinal Disorders and Respiratory Disease. This chapter begins on page 180 of your textbook. Make sure that you know those three key terms only for this chapter, so that's nice. And then we'll get into it. So, what are some disorders of gastrointestinal disease? Gastrointestinal system. We've got peptic ulcers, heartburn, Crohn's disease, irritable bowel syndrome, diverticulitis, gastroesophageal reflux disorder or GERD, and gastrointestinal cancer. So, we aren't going to dive into all of these, but of course, I do as always recommend that you read your chapter because it's important to know about all of these disorders, but we will dive into a few of the others, a few of them more directly. So, GERD is persistent heartburn, and this can mimic a heart attack, which can be challenging, right, from that medical emergency standpoint. So sometimes we have to help a patient determine what's happening exactly. There can also be burping and cramps and flatulence and feeling full in the stomach. A heavy meal can trigger GERD, which, if you remember back a few chapters, what else can trigger something? A heavy meal can trigger angina pectoris, which also can have similar side effects to a heart attack. So GERD can be a little difficult. Lying in a supine position can also trigger this. So for management of this, we may not lean our patient back as far, and that can be very helpful with avoiding triggering of GERD. Also, for patients, avoiding eating 4 hours before bedtime, of course, because you're laying down, eating smaller meals, and then medications that can help. In a dental setting, though, we definitely can help patients avoid this by not leaning them back so far in their chair, which can be challenging for us ergonomically, but also beneficial because we don't really want to have those symptoms that can mimic a heart attack or angina pectoris. Like, we don't want to be having to think about that type of a medical emergency. I always recommend, and because this is something that I do, if I have a patient that can't lean back very far, and some patients don't like to lean back out barely at all, but I will do stand-up dentistry too. So I won't lean them back super far, and then I may just raise the chair up or down as I need to. That way I can at least see in their mouth, and it's a little better on my ergonomics. So just remember, you have those adaptations that you can do for patients. So then we also have peptic ulcers, which is a Helicobacter pylori infection. And this, again, can be burping, heartburn, severe pain radiating into the upper body, nausea and vomiting, burning sensation in the abdomen, blood in the feces. Timing of the pain can be after eating or nighttime on an empty stomach. And management, again, is mostly medications. So for patients that suffer with like peptic ulcers in a dental setting, we may not want to see them like right after lunch or something, so that we can avoid some of those issues. So again, whenever we're dealing with some of these gastrointestinal disorders, what are we going to do and what do we need to be concerned about, right, from an oral health care standpoint? So right off the bat, we've got that upright positioning that I already mentioned, and don't be afraid to change your positioning too. Stand up if you need to. I guarantee it's not ideal, but you'll be glad that you did if you have a patient that cannot lean back very far at all. We're not going to recommend the use of like aspirin for pain medications because it's acidic and can exacerbate already existing GI disorders. Acetaminophen or Tylenol is great for dental pain for them. We're also going to examine their teeth for signs of erosion from acid reflux and even their increased risk of caries because they have erosion. So, they have more of that dentin exposed potentially. Daily fluoride treatments, whether that's in, just over the counter toothpaste or mouth rinses, or maybe we'll recommend a prescription strength or even fluoride trays if we think that is important. And then avoidance of toothbrushing at least 1 hour after their reflux, right? Because whenever they have that reflux, they have the acid, and then if we're brushing, that can increase the amount of wear and erosion on the teeth. So in the setting of seeing a patient with GI, our main adaptation and management is going to be that upright position. However, there's lots of other things that we're evaluating that we may need to take into consideration during the appointment, after the appointment, or recommendations that we make for them. So, one thing that can occur with some of these patients is that they may experience some choking. One thing with like GI disorders is that also sometimes people will have issues with like drainage because they have their body's trying to protect them against this GI disorder, and so they can have like sinus draining, which can cause choking. Now, we can also have patients just the possibility of choking on like a foreign object while they're in the chair, right? So, prevention, of course, is that semi upright position that they may already be in, scheduling more than 3 hours after their meal, and offer short breaks if we need them to, right? Give them a chance. They may even want like a sip of water next to them. I've had lots of patients that it's in their notes that I provide them with a cup of water before their appointment because they want that. We can use their saliva ejector a lot to help with preventing choking, and then allow the client to decide, right, whether we're going to continue or not. And they may need to reschedule. So another category of not GI, but acidic type of issues can be eating disorders like bulimia and anorexia. And we definitely have some of those oral indications in both of these. Anorexia, we may not notice it as much like orally because it's just the lack of eating foods, but we may notice it in some of our vital signs, like in a low pulse rate or very low blood pressure and decreased respiration. They may even have like a really low body temperature, which, as we know now, because of COVID, we are taking people's temperatures. So that may be something, if we routinely see that for someone. And we may refer them for medical evaluation if we need. Now, bulimia, because that involves purging or vomiting, that we may notice more of the oral cavity types of signs, like erosion, especially in the lingual of sextant 2 can be really common, enamel breakdown, and if found, of course, follow up. They may have tooth sensitivity because of the erosion. Of course, these, again, can be difficult conversations to have with our patients, right? And we don't want to make assumptions just because someone has erosion that they're bulimic or something, but having those, honest conversations, but being respectful of people. And we may be very certain that somebody is suffering with something like this, and the patient may still deny that they're struggling with a disorder like this. And we do need to respect their privacy, but sometimes we can be that final person that maybe cared about them enough to ask. But it's having those delicate conversations that can be challenging sometimes. Now, what about respiratory disorders, right? So these are something that can create a medical emergency in the dental setting, like something that we need to react to quickly. Um, Asthma is one of the main respiratory disorders that can be um, turn into a medical emergency in the dental setting. We also have chronic obstructive pulmonary disease, or COPD, which can be things like emphysema too, and chronic bronchitis. And so we may have to adapt in order to avoid medical emergencies for patients in that scenario, as far as like choking or aspiration of things go. Cystic fibrosis, and then, of course, management of respiratory disorders are the evaluate the respiratory sounds, stress reduction protocols, and no elective treatment if they're symptomatic. If someone's having an asthma attack, we're not going to treat them. And then keep an emergency bronchodilator, an inhaler, which we do have in our emergency kit available. Or, like we've talked before, if a patient suffers with asthma, they may carry their inhaler around. So if they have that, you have that conversation with them, talk to them about, okay, so what triggers your asthma? Have you ever had an asthma attack while you were at the dentist, or, in a healthcare setting? And then you can have that available. You may say, oh, let's just set it on the counter just in case. Like, I don't anticipate we'll need it, but I don't want to have to rifle through your bag if you need your inhaler. Um, Especially if they have those asthma attacks often. I have a sister-in-law who struggles with asthma, and she carries, her inhaler around with her like it's her keys and her cell phone. It's with her always. And I find it sometimes in places when she's been to my house, like my couch or something. So I keep my eye out for it too, to make sure that she always has it, or that she doesn't leave my house and leave it behind because it fell out of her pocket. But she always has it on her because she does get asthma attacks. Not often, but often enough that she needs to have it. It's not just exercise induced. We can also keep patients in a more semi-supine position, and then, of course, oral health education, especially for chronic medications. Asthma medications can sometimes lead to increased caries risk because those have to be inhaled. Oh, excuse me, through the mouth. So, what if we have that respiratory emergency, right? Most likely this is going to be like an asthma attack in the chair. So we talked about prevention. We're going to have the chair positioning, evaluate respirations, asthma control, selection of anesthetic, timing of appointment, and medical consultation if a patient doesn't seem to be in good health, or if they're having an asthma experience. My sister-in-law, again, like, she'll have moments where she just struggles with her asthma and she's had to use her nebulizer a lot. So I wouldn't see her when she's having more asthma attacks than usual. I wouldn't see her for like a dental hygiene appointment. We'd reschedule her and have her come on a time when she's feeling more under control and she's not having to use her inhaler as much, or her nebulizer and things like that. So, of course, if someone experiences, though, something like an asthma attack in the chair, we're going to terminate the procedure right away. We're going to put them in an upright position, give them 2 puffs of their bronchodilator, which if they use an inhaler, they're going to know how to use that, but we can, help them get the inhaler, bring it to them. We'll have supplemental oxygen if needed. And if it's unresolved, we're going to call 911. And if someone has severe asthma, we're not going to want to give them like sedatives and things like that prior to their appointment. And then, of course, we're going to avoid triggers, which, as we know, sometimes stress can induce asthma. So that's where those stress reduction protocols can come into play. So what if a patient has an airway obstruction, right? This can be a respiratory emergency, not in relation to like medical. This can happen for anything, especially if we have foreign objects in our patient's mouth, which, hello, that's all dentistry is, when we're providing care anyways. So, what are some signs and symptoms of airway obstruction? Agitation, placing hand on the throat, coughing or wheezing, cyanosis of the face and the lips. Prevention in the dental setting can be using our saliva ejector or the high evacuation suction, careful observation of items that we're using, and when we're doing things that a rubber dam can be utilized for, that can be very beneficial too, because like if you're placing a crown, which is a hygienist, of course, we're not placing crowns, but if we're helping assist with one, and you're placing a crown, the rubber dam is going to catch that crown if it doesn't stay on the tooth or it slips out of your fingers or something. So for management, if somebody, something even just falls into the back of their throat, we're going to bring their head forward, allow coughing to expel the object, and then of course we're going to initiate the Heimlich maneuver if that object is not expelled, which you all learned in your basic life support classes. And that is it for chapter 13. So make sure that you do your flowcharts, read chapter 13, read your other resources for information, and then turn in your flowchart according to the due date in D2L.